Allocated time. And you will all get a screen prompt to accept. We've allocated time at the end of this meeting to respond to questions received in advance from members of the public, and thank you very much to our member of the public who has asked one question, which we will be responding to. I want to open the meeting by saying on behalf of NHS Frimley to formally record our condolences to His Majesty the King and the rest of the royal family and household on the loss of Queen Elizabeth. For most of us, she's been the only monarch we've known, and her presence was felt very strongly within the Frimley health and care system because of her fondness for this area and her home in Windsor. It is somewhat poignant for us to know that her last engagement in public was when she opened the new home of Thames Hospice near Maidenhead in July, accompanied by Princess Anne. And I want to pay tribute to all those from Frimley Health and Care and all of our partners and other agencies who worked tirelessly to ensure that events in Windsor went according to plan on Monday. It was an enormous logistical effort for so many organisations and individuals, from the royal household to local volunteers. And the fact that everything went so smoothly is testament to the enormous amount of planning and preparation behind the scenes. I think we all want to say on behalf of NHS Frimley how proud we are of all our colleagues for the roles they played in this historic event and for ensuring that it was a fitting tribute to the memory of our late Queen. Thank you again to all of our teams. As we move then to our agenda, our first item is the conflicts of interest register and declarations of any items of interest relating to this agenda. The conflicts of interest register remains a work in progress, with several members of the board currently in the process of updating their declarations. And so a further updated version will come to the next ICB in October. In the interim, does anybody have any interest to declare in relation to today's agenda? I'm just flicking through screens to make sure, and I have no. Thank you. The minutes then of our last meeting in public, which was held on the 19th of July. Any amendments? Any other matters which are not already covered in the agenda? Thank you. Let's move then to Fiona's report. Thank you, Fiona.
Right, good afternoon, everyone. Unprecedented times for us, our staff, our partners across the system. And as our chairman eloquently described, the way everyone pulled together was phenomenal, and particularly my thanks to our emergency preparedness team and the teams in all the partner organisations, particularly around the Royal Borough of Windsor and Maidenhead, that worked well together and have worked over the weekend and supported safety within our communities, and the sad events were managed safely for people to be able to express their condolences. Prior to the last couple of weeks and looking into winter, we're facing again unprecedented pressures both across our urgent and emergency care health systems, which really illuminate and show the pressures in all parts of the public sector post-pandemic, sort of attempting recovery across all of our services, but also ensuring a safe and effective urgent and emergency response. So we in the system have done a great deal of work both to look at quality and safety as it manifests itself in the urgent and emergency care response. We held a joint quality summit about 3 weeks ago, which is informing some immediate short-term responses and designs to as we move into winter and preparing well across all of our services, both in terms of vaccinations, urgent and emergency response, and continuing the waiting list recovery. I think the last thing I wanted to reflect on really was the astonishing commitment of our staff across our health and care system. My colleagues and I had the pleasure of meeting a number of our allied health professionals this morning in the first effectively face-to-face conference that we've had as a Frimley system with staff. And our allied health professionals include physiotherapists, dietitians, and people working to support the third largest clinical workforce after doctors and nurses in the NHS system. And those staff work across integrated teams and across the interfaces. We had our theatre matron talking about deployment of support staff to work effectively to plug and retain staff in where levels of resilience are feeling quite low with the scale of pressures and responses that we have to deliver, and also the level of vacancies we have across health and care. And I think it's just a tribute to the staff there at that conference, who are just an example of the staff we've got in public service, who really, in spite of the exhaustion, in spite of feeling we're going to face a really challenging winter together, we really need to work well in support and the support of our public in working well together to help people keep well and safe as possible. That people are just really up for trying to work well and innovatively and co-design together, and in spite of their exhaustion, really want to continue to do the best they can. So I found it very heartening this morning to be with those staff, and it is an example of the calibre and commitment we've got across health and care staff, in partnership with voluntary sector as well. When I say staff, I mean everyone working to support our residents and patients and members of the community. So a really tough time ahead, but we're facing into it well, and you'll see the agenda is designed to cover how we're building our approach together across the system. Thanks.
Thank you very much, Fiona. Are there any comments and questions for Fiona initially? Thank you. We'll move then to our Living Well ambition update. You'll recall when we met last time, we are taking in turn a number of our areas of ambition and strategic areas for development. And the first one we examined last time was the Children and Young People's Review. Today we're looking at Living Well, and thank you to Lalitha Iyer for leading on this, and also Ollie Hemmons for supporting with the slides. Thank you. Over to you, Lalitha.
Thank you, Priya. Ollie, may I have the first slide, please? Thank you. So I want to begin by saying that this ambition has Tim Ho, who is our medical director from the Acute Trust, as the sponsor, and the convener, who is the Chief Public Health Officer from East Berkshire. And I've also got Mahmouda, who I have to thank for some of the slides that she's put together. She's a really passionate program lead within this ambition. Next slide, please. This is a very familiar picture for most of us. Identifies all our 6 ambitions, the colourful rainbow, talking about how we want our people within the ICS to start well. We want all children to get the best possible start, and then we want our people to live healthy lives then takes us through community deals and how we look after our people and the culture within our ICS, and also how we use our resources. But what we got to remember is that in order for us to deliver any of these ambitions, be it focus on well-being and living healthy, long lives, it is not just about us working either as a system or a place, but actually working across various levels. So if we take the person and the family in the center, we have to be mindful that their links with the community and neighborhood are strengthened. We need to work with the locality and places they're at. We also need to work as a system, but also across the system, because many of our residents actually cater across systems for various services, be it social care or health. Next slide, please. So what is our Living Well ambition? So just want to identify a few little things. We want our people to live in good health for longer. We want them to live and age well, live their lives to the fullest of their abilities. But within this, we want to be able to identify and target cohorts of people who need a little bit more help. So be it because of deprivation or other inequalities, or because their needs are very complex, these are the cohorts of people where we need to focus a little bit more. We are quite conscious that we need to have a sustained focus on the intra and interplace health inequality. So we know that between our places, there are slightly less deprived and more deprived communities, but also within each place, there are pockets of deprivation, and we need to ensure that we're aware of these and cater to the needs of all these people and level up accordingly. The biggest success for us in this ambition is that it is sponsored and delivered by teams, not from one organization, but actually delivering across organizations. And we are working collaboratively to understand the needs of our communities and build on what their desires are. And this will then help us actually create a culture of prevention and self-care. Next slide, please. So I just wanted to touch a little bit on the principles influencing the Living Well approach. I'll touch on the logic model in the next slide, but I want to just ensure that we all are aware that in order to make the Living Well ambition work, we are using a population health management approach. Our priorities actually come from community insights and co-design with residents. So it's not about doing to our residents, but actually learning from them what they want and how can we support them within the places that they live in. And how we deliver is predominantly influenced by the way we've been working across Frimley, a partnership approach, which focuses on health inequality, networked across the system rather than working as silos. And as partners, we don't really performance manage, but we hold each other to account. Next slide, please. So this is the logic model I was talking about. So our aim is that we want to increase healthy life expectancy at birth, because we know that even within our ICS, the minute a child is born, in some places, they are destined not to live as long as in others. And that's something which is a stark reality that we want to change. We want to reduce the gap in healthy life expectancy between our least deprived and most deprived communities. And how do we do that? So if you look at the box at the bottom, we know that increase healthy life expectancy and reduce inequalities is not just about the medical factors. We have the wider determinants of health, such as income, employment, education, housing, and so on. We also have the physiological impacts of medical factors, such as high blood pressure or cholesterol, or indeed mental health problems. We know that behaviors such as smoking, alcohol consumption, inactivity, all of those impact on how a person lives and feels. And there are a multitude of psychosocial factors, such as social isolation, the support you get, the networks and the connections where you live. So if you go to the box at the top, in order to achieve a better life expectancy and reducing health inequalities, it seems to be a combination of life's chances, social determinants of health, cardiovascular disease, respiratory disease, cancer, and mental health. So when we looked at it in detail, it's quite clear that you need a multi-pronged approach. You need a primary prevention where you create conditions where living well is possible by encouraging healthy behaviors. We do need to manage risk factors because, unfortunately, whether we like it or not, some people will have these risk factors of cardiovascular disease and respiratory disease. But If they've got a problem, then we also need to have tertiary prevention, such as enabling early diagnosis of cancer, effective treatment, so that even if they have a problem, they can be treated early, treated well, and therefore live well for longer. Next slide, please. So this is just a quick summary of what has been agreed by the group on the main 3 Living Well system-wide priorities. Places did have many other priorities, and I've summarized that on a different slide. But the 3 main priorities for us as an ICS is cardiovascular disease prevention, healthy weight, and smoking. So with cardiovascular disease prevention, what we've done is we have created an ICS-wide CVD prevention group that's been established. There's a diverse range of colleagues from public health, voluntary sector, places, system, and so on, so that we can actually develop a menu of opportunities. Now, cardiovascular disease is a big topic, and we've decided that we're going to focus initially on hypertension. We know that nationally there's a drive on hypertension because if blood pressure is not well controlled, people can have strokes, and the quality of life and the impact on their day-to-day life and the impact of need for social care and support is quite high. And it is quite an easy condition to detect and treat. And that's why hypertension has been chosen as the predominant factor. What we're trying to do within the group is oversee different activities that happen at place and bring things together, learn from each other, collaborate and share and support. In healthy weight, in summary, what the group that has been established is trying to do is to increase the proportion of adults and children who are of a healthy weight and reduce the proportion of children who are obese. So essentially optimizing weight management, and I'll touch a little bit on what we're doing for that. With smoking, again, Frimley Health Smoke-Free Steering Group has been established. And what this group does is we are aiming to implement the NHS LTP long-term plan objectives relating to tobacco. We want to drive a smoke-free agenda across the ICS. By 2024, we want every patient who is in the acute hospital, be it for maternity or for anything else, to be offered an opt-out tobacco treatment services so that their smoking status is logged, they're given enough support to actually stop smoking. We want to ensure that we work collaboratively with our local health, public health partners, and also work collaboratively with the services at place. Next slide, please. So as I mentioned before, there were many priorities that various places have identified, but we needed to pick a handful as a system-wide priority while enabling places to achieve the rest of their priorities. So you'll see here, there's a lot more happening at place, but I'm predominantly alluding only to those 3. Next slide, please. So it's just again, a quick run through of some examples of the work we've done. So for hypertension, what we've tried to do is enable people to understand, what is my normal blood pressure? What are the actual readings? If I get a blood pressure machine and I take my own measurement, when do I need to take action? Or if I go to a pharmacy and have my blood pressure taken, when do I need to take action? So we have created a web page for CVD prevention. Our comms teams are really active in the social media space, and our GPs and pharmacists have created a lot of videos which talk about how do you take your blood pressure? Do you sit down? Do you stand up? Where do you put the blood pressure monitor? Simple things like that. We're also running a lot of campaign work specifically at various places, be it a bus going into communities who find it hard to reach other places, or be it the pharmacy taking our patients' blood pressures. There's also an opportunity with vaccination sites, which has been used for some time, and many other places are going for this. So if a resident goes in for their COVID vaccination or flu jab, why not check their blood pressure as well, just to make sure it's all fine. So we've got various things, and some of you will find a few places mentioned, such as Lakeside and Surrey Heath, where they had hypertension focused days, where we had a large number of patients coming in. AccuRx Flori there is just a texting service for patients from practices where the GP can actually write back to the patient, ask for their blood pressure, log in the blood pressure that the patient sends back. And if it is high, actually the clinical pharmacist team or any of the clinical teams can respond and appropriately ensure that the patient is treated. Next slide, please. So again, gives you an idea of how it is not clinically led alone. It is actually a multi-pronged campaign. So we've got campaign with supporting resources being sent to patients in various languages. We, of course, have GP and clinician-based services, whether it be at the practice or at the pharmacy. We've also got community blood pressure monitors. So places like gyms and other community centers having blood pressure machines so that people can check their own blood pressures. And let's not forget our own staff. So making sure that our staff are encouraged to drop in for their blood pressure. And if they know what the normal blood pressure is, they probably go home and create a ripple effect among their friends and families and encourage others to have their blood pressure checked. Within all this, we're trying to ensure that we have enough connection that if a patient's blood pressure or a resident's blood pressure is logged in or checked, that we can log that in within our GP records so that the clinical care records of every resident is actually updated. Next slide, please. So just a little bit about healthy weights. So we're working in collaboration with local authorities. There's an NHS digital weight management program. And actually, I'm proud to say that our ICS is the highest performing system in the country in terms of uptake. We must remember not to forget people, for example, with learning disabilities, so that there's enough information for them easily accessible with easy read leaflets, etc. on the public website. We have created forms for referral for our clinicians when they work in primary care. And the good news is that all 5 of our places have a thriving tier 2 weight management services. And we've got a whole system approach to obesity, which is essentially all of Frimley, but working with the places. And you see on the slide a few examples of Rushmore and Surrey Heath, but every place within the ICS has had some form of a workshop or other in order to roll out education in relation to healthy weights. We're also engaging with Get Berkshire Active to explore the active practice idea, where the practice is encouraging patients. We are rolling out physical activity training in secondary care, and a lot is happening in this space. Next slide, please. Smoking, we know that we've got our tobacco NHS LTP long-term plan dependent services. So what we've done with that is that we are starting a 3-year program to deliver the tobacco dependence treatment services in line with the NHS commitments that we have to make as part of the long-term plan. We have senior level trust support and tobacco dependency steering group in place. We've developed a model where the trust can actually provide continuity of care from specialist advice about stopping smoking right through to the ongoing provision of pharmacotherapy. But at the same time, if the patient wants to follow up in the community, that there's actually linkage between what's being provided in the community and what's being provided in the trust. And to that extent, we've recruited 3 inpatient tobacco dependency advisors, and we are also promoting Stoptober, which many of you would have heard about. And we are trying to make sure that workplaces are smoke-free, and we can ensure that information is available easily on the ICS webpage. Next slide, please. This is just again a quick summary of the various things that are happening. So investments have been created, not just in resources for people and staff, but also in providing additional blood pressure machines. So NHS England gave us some blood pressure machines to give out to patients where, for example, were deprived enough not to be able to afford to buy a blood pressure machine. So they were given these machines so they could monitor their blood pressure. Some of them were hypertensive, were known hypertensives, but hadn't had their checks because of COVID and so on. So we are really mindful of making sure that we are looking after our most vulnerable. So you'll see on the left-hand side box of the various investments. And I suppose we've already seen benefits from these investments, where we're seeing closer collaboration, partnership working with health and local government and voluntary sector. We're also seeing that the communities are beginning to feel more strengthened by recognizing, identifying, and harnessing the existing assets, because there's a lot that we can harness from already existing assets. And we're also finding a lot of collaboration, because stakeholders are all aligned. We want to ensure that we achieve the best for our people in this ambition. Now, measuring the impact of this ambition is complex, because we will only see this as avoided admissions, but regardless, we know that by this ambition, we will be allowing services to deliver care for increased number of patients while increasing quality, self-care and compliance. So really working with Public Health England, we will be evaluating the engagement aspect of this work as well. Next slide, please. This is a busy slide, but it's just a summary to show you that there's a lot happening in this space. So in all three aspects, be it the hypertension, CVD prevention, that is cardiovascular prevention, or be it smoking or healthy weights, there is a lot that is happening as key priorities in the coming year. And we are really keen to explore staff offers of support as well, whether it's for smoking, healthy weight or hypertension. We want to roll out staff NHS health checks. We want to ensure that we contribute to the core 20+5 approach, which is where we look after the 20% most deprived of our population within the ICS. And smoking, for example, runs through all our 5 other priorities for these 20% of the population. We want to ensure that we have more smoke-free sites across our services to ensure that we achieve all our objectives over the next few years. Next slide, please, which is probably my last. And with that, I just want to say thank you. And the more we can spread the message, the better for our residents. Thank you. I'll stop there, Priya.
Thank you very much, Lalitha. And now, do I have any comments or questions?
Yes, please.
I'm so sorry, Mr. Chetri. I won't be taking questions from the public.
No, it's not a question, it's a suggestion.
I'm not going to take any suggestions at the moment. We'll follow up afterwards.
Thank you.
Any of the board members with comments, questions? Karen Edwards, please. Karen, I can't hear you. Can others hear Karen? No. Okay. We'll move on and then come back in if you can. Okay. Well, thank you, Lalitha. That was really helpful. That clarity of priorities, alignment of investment, and seeing value for money with seeing the benefits and impact, and clear collaborative learning across the system. Really good to see. So thank you. Let's move then to our next agenda item, which is a proposal for a mirror board. And over to you, Safina.
Thank you, Priya. So hopefully everybody's had a chance to read the proposal. It is a conversation we've had previously around developing our mirror board. So just a thank you to Vicky Ward, who's put the kind of proposal together and done lots of research around other organisations that have had a similar model. So so hopefully everybody's had a chance to have a look. I think the first bit I wanted to talk about was the actual data which we've included in there. That tells us actually there's a good case for wanting to do this, because we know in terms of representation, specifically around Black and minority ethnic background in terms of boards, we are underrepresented. So I just wanted to kind of highlight that data. I think one of the things that we've said within the board meetings is that we'll continuously develop our data and have really good robust data sets to back up any interventions that we're doing around EDI. So I think, you know, in terms of the mirror board, it's not many other organisations have done, NHS organisations have done this model. Bob is looking at doing something, but I think are really looking at us to start that off and see what it looks like and then develop theirs. Private organisations like Gucci and other kind of organisations have done it to help with kind of younger, having a younger kind of perspectives for young people and older people. So we've done some research into that. I think I just wanted to kind of focus on the benefits of having a mirror board, and focus people on kind of 4.3 around what does the board think that or suggest in terms of the aims of what the mirror board would be, and to that kind of, to follow on from that, how do we want to recruit members of the board? So I really wanted a discussion today, thoughts from people around how we go forward. But I think we know the benefits. You know, we've got kind of that diversity in decision making, looking at board papers through an inclusion lens, succession planning. These are all some of the benefits that a mirror board would bring. So I just wanted to kind of get thoughts from people in the room in terms of what they prefer.
Thank you very much, Safina. And may I ask for comments and questions, please? Ilona Blue and then Graham Wareham, please.
Thanks, Priya, and thanks for the paper. I was just going to say, I've seen this model operate in other organisations, and it's been incredibly powerful. So I'm hugely supportive of the proposals, really happy to work offline kind of as we build up the detail of how it might work. My sense is that the key thing is ensuring that a representative from the mirror board has a really strong voice here at the ICB is the key to its impact and success. So, and I'm sure we can figure out what that means in practice, but that's what I'd be looking for to ensure we get the best value from a mirror board. Thanks.
Thank you. Graham?
Thanks, Priya. I really love this paper. And mine was really an offer to say, if we are setting up the mirror board to map all the ICB roles, then I'd be happy personally to mentor, if you like, support, reverse mentor my mirror, if you like, because I think for them to add the best value, actually having a sort of bilateral relationship with our mirror would be really helpful. So that was my thoughts.
Thank you very much. Rachel Worrell and then Alex Guild, please.
I was really interested in the distinction in the paper between a shadow board and a mirror board and the careful sort of choice of language there. And to my mind, at least, a shadow board implies kind of something that follows, you know, closely the existing board, whereas the mirror, the idea of a mirror sounds kind of more confronting in some ways, which I think sounds very healthy. So I think it'd be worth our while really explicitly exploring what we mean by the ethos that we're expecting comes with the word mirror. It sounds really positive to me, and I'd be very glad to encourage that, and certainly willing to volunteer with Graham to mentor my mirror.
Thank you. And Alex?
Yeah, I think this is a really exciting proposal. Holding a mirror up to ourselves does feel very powerful as a new board. I think there's the opportunity to create really long-term reciprocal mentoring relationships in that mirror sense. So fully support that element of the proposal. I think thinking about the benefits and the aims is really important for the board to do now in terms of the approach it takes. So, you know, how brave do we want to be in terms of really reaching out and into our wider partnership and community? So, you know, option C on page 5 covers that for me, and in particular brings in potentially lived experience of health and care services. But, you know, we could be on a continuum here around development in terms of how we stage this. I think for me, it's less about succession planning. It's more about the mirror element of the board's and the board's business, and giving people an opportunity actually to be with us in the board. I think there's a brave element about both public and private sessions of the board, and having people here with us, because if it's about developing system leadership and future leaders, then they need to see the discourse that board members have over the papers, rather than studying papers in advance and then not hearing the conversation. So I really support having people in the board with us.
Thank you very much. Safina, did you have any comments?
Yeah, I think as part of the programme, definitely the reciprocal mentoring is going to be a key part of that. So everybody on the board will be kind of reciprocally mentoring somebody. I think a decision around that ABC would be good, and I think, as Alex mentioned, you know, we can have that kind of diverse people in the room, but actually that inadvertently will kind of bring that inclusion and diversity lens into the papers if you've got a diverse group in terms of a mirror board. And then the other thing I wanted to kind of highlight was around the chair of that mirror board. And Priya, you and I had a discussion around who would do that and whether that would be a role for me with that kind of board champion role alongside that, which means that in terms of the board, this board, there will be that presence there. But also one of the things that have come up in the engagement is whether the mirror board members can actually attend these board meetings as well for experience and exposure.
Thank you very much, Safina. I think we have unanimity in support for the concept of a mirror board, primacy of bringing diversity of thought to board discussions, and the mutual benefit that will bring to this board and the mirror board. The details we can then look to ask you to work up, Safina. I think there's real clarity about roles as they enter the mirror board, and support for this to be a really positive experience, which feeds into board succession planning and development of pipeline of people with an interest in leadership. So thank you. So thank you, everyone. And let's move to our next agenda item, which is the urgent and emergency care strategy briefing. And we'll hand over to Sam Burrows.
Thanks very much, Priya. And I'm hoping that Ollie's going to share this. Look at that. Fantastic. Thanks, Ollie. So there's quite a bit to get through in these slides. We've only got 10 minutes. So with permission from colleagues, I'm going to canter through it relatively quickly to give you headlines. We'll make the slides available afterwards if there are things of detail you wish to go into in your own time. And I want to make sure we've got some time for questions afterwards as well. So Ollie, I'm going to clip through these pretty fast, but by way of background, you'll know that our system is under a period of quite significant pressure at the moment, a number of challenges in urgent and emergency care. And I want to be really clear, it's quite a broad definition here. This is not just about what happens inside emergency departments, although there is pressure there, of course. This is an impact which is felt across all parts of the health and social care sector. Many of the issues are, as we continue to recover from the COVID-19 pandemic, which is to an extent still ongoing, and are novel and are new to us, and we continue to learn our way through that. But other issues are exacerbations of things which have been challenges for a number of years. And to improve this, we've been working as a partnership over the summer to develop a new urgent and emergency care strategy for the whole Frimley Health and Care system. We've been working with our clinical and professional leaders over that time. We've had over 120 stakeholder interviews with clinical, social care colleagues and others. We've also held a number of cross-system and cross-sector workshops and working groups to work through the detail of what this strategy should contain, inside of which we now have something which contains our objectives and our guiding principles for any future decisions and developments that we take as a system and how we continue to evolve the way that we work. So in the next few minutes, I'm just going to walk you through the core objectives of that strategy, the enabling objectives that go alongside it, how this translates into immediate action for the winter ahead, and then a little bit on future focus for 2023 and beyond. Thank you, Ollie. So our vision in the strategy is this kind of statement in the center of your screen here, that our local residents receive safe, connected and reliable care to support them when they need it most. And we found that this statement, when tested with colleagues, really resonated with people, and that it made sense to people as well, as something which we would all instinctively aspire to, but it is the vision which guides the rest of our strategy as a whole. Next one, please, Ollie. And again, testing this with a number of partners over the summer months. These are the things which our colleagues said they wanted to be known by as when thinking about our system delivering UEC services. So patient-centered, really fast adopters and implementers of technology, flexible and agile when we need to manage those periods of real pressure, integrated with shared resources, shared workforce, shared goals and objectives, and thought leaders with a real reputation for continuous innovation and improvement. And again, that feels really, for me, very much aligned with our ICS vision and values and ways of working. And these are, in summary, the core objectives of the strategy. Now, I'm going to run through these in a touch more detail in a second, but this is, if you were to look at the strategy on a single page in terms of its objectives and outcomes, this is what it looks like. So we've got our vision statement at the top there, 7 kind of key core outcomes running along the green strata there, and then 4 core objectives and 4 enabling objectives. So I'm just going to take a minute to run through the objectives. Go to the next slide, please, Ollie. So our core objectives, one is to understand the needs of our population and deliver equitable clinical outcomes system-wide. This is very much our ICS strategy that we've had since 2019. Lalitha showed you that earlier on in her presentation around living well, and it really is the umbrella which overarches the entirety of this. This is around population health management and improvement, and supporting the population to really receive that equitable care where we're reducing health inequalities and improving healthy life expectancy. Objective 2 is around supporting more preventative interventions that are proactive and really help people look after themselves in their home setting, and reduces the need for them to access urgent and emergency care, except for when it's absolutely necessary. Thirdly, to adapt our offering to improve access and delivery efficiency. And finally, for the core objectives, to ensure that there's a timely exit when people are ready to come out of the most acute parts of our system, and to ensure there is real continuity of care for patients as they step through from entry all the way through to exit. So those are our 4 core objectives. And in terms of our enabling objectives, there are 4 more. So our first one of those is around workforce. We know that workforce is probably our single greatest challenge as a partnership, not just in the NHS, but across social care as well. Our second is a new operating model that more adequately helps us to reduce the complexity of the system, share risk more effectively, and just to create greater sustainability and additional resilience as well. Objective number 7, the third enabler, is a real focus on transformation and really ensuring that transformation flows through everything that we do in this space to really drive that degree of improvement. And the final one is working with our population to improve patient awareness, co-production, engagement and empowerment of local people to ensure that we're in a meaningful dialogue with them and help them, support them to receive the best level of service which they would rightly expect from the public sector as a whole. So those are the 8 objectives in totality. Want to keep going, Ollie? And this is what it looks like when you map those across this quite busy diagram. So it really shows you from left to right, those very preventative objectives which we touched on, and some of the things which might sit within those. Then you've got access into the urgent and emergency care sector and the improvements we can make in those spaces, and then the exit and into the continuity of care that exists beyond the hospital sector. And overarching all 3 of those things across the top is our focus on population health and population health management. And those 4 things taken together and shown in that left to right sequence, I think should hopefully start to give you an idea of how our objectives stitch together to improve the continuity and integration of the care that we offer to our population. I'm not going to go into the detail of these slides, but I really wanted the board to see that the strategy is already starting to convert into some immediate action. So we've defined 3 phases for our urgent emergency care improvement priorities. Phase 1 is very much around organising ourselves to improve delivery. We've got a number of initiatives on this slide which focus on our internal ways of working and working with our partners on new things which we can improve and do better, preferably before the end of September, and will get us into the best possible state for managing the winter period ahead. Can I have the next one, please, Ollie? And you can see these start to plug into phase 1 in this way, mapping against the 8 objectives that we touched on a moment ago. So at the moment, you can see the way this is coming together is very much focused in the most part on our organisation, with some additional bits around improving access ahead of the core winter months. Next slide, please, Ollie. And in phase 2, which is ahead of winter proper, a whole raft of initiatives which focus on improving access, improving integration, and improving capacity as well. We've got a collection of 11 improvement schemes here, which we are looking to really accelerate as we go into the really core winter period. Again, a lot of detail on this slide. I'm not intending to go into it in any great degree. This is still very much in draft and continuing to be worked up, but we thought it was important that the board was seeing some early sight of this at this stage. Go to the next one, please, Ollie. So the picture is building, as you can see, on the objectives. So here we have into our core blue objectives, 1 to 4, those improvement opportunities started to populate against the first 4 core objectives that we spoke about in the start of the presentation. And we'll go to phase 3 now. And phase 3 are the longer term improvement opportunities, which are contained in the bulk of the detail of the strategy. Again, huge amount of information on here, which I'm not going to go into today, but I hope that for the board, you can start to see how it is shaping up and coming together. All 8 objectives having some discrete and well thought through improvement opportunities, which map against all 8 of those things, which when taken together will improve the sustainability and resilience and quality of the UEC services which we provide to the population. Nothing else in the presentation from me, so I'll hand back to Priya, hoping there may be some questions from colleagues.
Thank you very much, Sam, very clear. Comment and questions from colleagues. I think some people have been actively involved at all stages of that development. Oh, Karen, come on.
I'm going to try again. Can you hear me
Yes.
this time?
Yes.
Perfect. Sam, and I realize this is a really mean question, but the workforce sort of box remained empty until phase 3, and we're currently mid-September. So I suppose my question is, are there any actions that can be brought forward to sort of address what we know are the current issues that have been outlined a number of times today?
So firstly, it's not a mean question at all. I think it's perfectly fair and legitimate. So thank you, Karen. And secondly, the answer to that is an unequivocal yes. And it's something which Caroline raised with colleagues on Thursday. We're continuing to work through that and getting it populated, working with the People Board, which has got a really kind of key and core role as a part of that. Caroline, is there anything you wanted to add? Because I know this is something which is you're kind of keen to ensure we do accelerate on ahead of winter.
Yeah, I think thanks ever so much. And yes, Karen, I think we can better represent some of the work that's going on across the system. There's examples in a variety of areas. One that immediately comes to mind is the work we're doing as a system, now extending to 9 trusts on temporary staffing. And the rates now that we're paying to agencies as a result of combined purchasing power. There's work as well around different and basically a MOU to enable the sharing of staff immediately, because we've worked through some of the processes that were blocking that. So yes, I think we can represent better some of the immediate work that's going on, as well as the more strategic or perhaps longer term pieces that are going to take a little while longer to get in play. But as Sam said, very actively engaging with colleagues to best represent, try and succinctly represent it as well.
Thank you.
Thank you. And final comment from Prash. Thank you.
Thanks, Sam. This is an immensely complex area, urgent and emergency care, as I'm sure everybody recognises, and certainly it's interesting to have this discussion in public. As a clinician for sort of over 20 years, the tricky part is I think most people will agree what an emergency is, but I think you alluded right at the start, Sam, about what actually is urgent. My definition of what is clinically urgent is very different to what a member of the public thinks is urgent, and then that can be defined across the board with a variety of inequalities. I don't think we're going to be able to find the answers, because certainly over 20 years, and I remember when I first started accident and emergency, one of my old professors talked about, and back then there was some power to say to a patient, this is neither an accident nor an emergency, so please go back to wherever it was that you came from. I suppose we've got to be a little bit more evolved in how we deal with our communities, and maybe this is the opportunity as we work as a system. And I'm interested, I know that there's the workforce issues, but I'm interested, I suppose, in what our local authority partners could do with perhaps moving that discussion to our communities into this idea of, and it'd be interesting to see whether any other clinicians have this view, but we've got this thing between want and need. And I wonder if we, you know, for our communities, gone has needing a diagnosis, but wanting reassurance. And I wonder if often we are asking for assistance because we're wanting reassurance rather than needing a diagnosis, but that actually takes up a lot of time and capacity. And I suppose we've never really understood across the system how we differentiate the demand a little better. But I suppose, Sam, part of future thinking as we develop the strategy on urgent and emergency care is this where we use data and analysis? Is this where we actually start to gather information, maybe from our secondary care colleagues, about what it is that's presenting, and whether we can try to have those difficult conversations between what is appropriate and what is inappropriate. I wonder whether our strategy needs to move away from the politics of saying, yes, you can have every bit of care and attention that you require. That's obviously a goal, but I think we really do need to have an honest conversation with our communities about what is an appropriate presentation and what is an inappropriate presentation. And perhaps sometimes if there is an element of delay within the system, then so much of what we know clinically is self-limiting may actually emerge as just that. And so there's a fine balance between making sure things are done in a timely fashion, but often if things are not done, but actually sometimes waiting for things, watchful waiting, actually may allow us to try and manage that differentiation. I don't know, it's immensely complex. I think the strategy we've outlined is excellent. I think the fact that we've got an opportunity to use the analysis across system partners and to do this as a group is very interesting. But it will be interesting to know whether we've got any ability to start to have a wider discussion with our communities about presenting their problems in a slightly different way. Certainly from a clinician's point of view, that might be something that our local authorities could help as we try and bring that conversation down to community level.
Thank you, Prash. Sam, do you have any comments?
I think there's a huge amount in what Prash says in there that needs unboxing and is part of the core challenge that I think we're trying to solve. The mode of our collective operation is shifting and will continue to have to shift. And the things which we focus on tomorrow are very, very different to the things that we focused on yesterday. For example, you know, we're now starting a new piece of work around keeping people warm over the winter, because actually that probably is the single greatest driver potentially on predictive admissions than anything else we could possibly do. I think 6 months to 12 months ago, that maybe wouldn't have even come across our radar potentially, but the world changes around us. So I think, you know, my takeaway from what you're saying, Prash, is that everything has to be on the table in how we work with our partners and our public to ensure that we've got a system which meets as many people's needs as is possible. So really welcome your comments.
Thank you very much. Thank you, everyone. So we have the start of our urgent and emergency care strategy, and that has been really clearly outlined. Thank you, Sam, with the comments there about where workforce will be represented in that first tranche. And of course, part of it is always about building resilience within ourselves and our communities, both in those provide care and those that seek it, because we are committed to that being the best experience for people as well as the best outcome of care. So thank you, everybody. Moving then to our health and care system update, and back to you, Sam.
Yes, sorry, I seem to have taken a large proportion of the floor for this half of the meeting. So again, I will try and get through this one relatively quickly. Everyone has had this paper, so I'm not planning to give it as a formal presentation, but I will pull out a few things for highlight. So Ollie, if I could have the next slide, please. We shouldn't need to dwell on this one very long because Lalitha has done this job for me. This is our strategy. It's been our strategy since 2019. It has 2 objectives and it has 6 strategic ambitions. We have discussed this in the meeting already, so I think we can probably keep going. And just to note that in the middle of the summer, the Department of Health and Social Care published some new guidance on ICS strategy development. We were expecting this, and is part of our move into post 1st of July operating. And it's kind of some very quick headlines. So we are required to publish an interim strategy by Christmas. That strategy can be our current strategy, but we will be seeking to refresh it and make sure it's fit for purpose for where we currently are. As you'd expect, the strategies should be informed by JSNAs and Health and Wellbeing Board strategies, and should focus on things which bind the whole ICS together in terms of common objectives and common challenges. There are some suggested focus areas, which you can see in the middle there. All of these things will be covered in our ICS strategy because all of them currently are, and strategies are expected to be multi-year and refreshed when new JSNAs are refreshed as well. We have 5 JSNAs in the Frimley system from 5 upper-tier local authorities. So the coordination of that is not necessarily as simple as this slide may make it sound. Have the next one, please, Ollie. And we're proposing to be tested with our ICP when the ICP forms and meets for the first time next week. That's the Integrated Care Partnership, on views on our current approach and whether we should retain our current 6 ambition strategy. I think there's a really strong view from those who I've met with informally over the last couple of months that we should. This is to a large extent unfinished business. We still have much to do in these 6 areas, but how each of these ambitions is configured and what the focus areas of those 6 ambitions may be, I think is very much up for discussion. And we're really looking forward to the ICP getting into some of those conversations over the next few months. The next one, please, Ollie. Now, in terms of how we identify those new priorities and focus areas, there's a few kind of really key building blocks for things that we have learned over the last few years of how we work together that are successful, and we'd want to retain those things. The first is that it's really evidence-based and that we make the best use of our really rich data and information that we have in this system. We have the shared care record, we have the connected care data set, which really gives us the ability to generate fantastic insight alongside JSNAs and Health and Wellbeing Board strategies. Secondly, that we're very, very fortunate in this system to have third sector and voluntary sector partners who really want to be involved in this work. They want to be part of the conversation and to bring their expertise together into a space where they can help us really generate our focus into the right areas, and we're really welcoming of that. And the third and final thing is that we're not starting with a blank page. We already have a very well-defined strategy. The refresh is welcome and helpful, but we have other complementary strategies that really spin off out of that, which we will need to keep going. Some of those are health and wellbeing strategies that come through health and wellbeing boards. Others sit in a more kind of complementary space around the outside, but we don't want to throw everything out as a part of this process. There's much good work to be retained. Next one, please, Ollie. Now, just a quick reminder about the ICP, which forms next week. The ICP, its kind of core statutory function is to consider and approve the ICS strategy. The ICP meets for the first time next week. It meets again in November, and then it will meet 3 to 4 times a year beyond that. We really want that forum to be a space where we can consider the wider determinants of health, not focused purely on health matters, but looking at those things which we know have a huge and significant impact on people's health and well-being, whether that's housing or skills or employment, education, and many, many other issues. Where we know the expertise does not sit within the NHS. And the ICP is a great opportunity to bring people together in order to do that effectively and in a way which informs the strategy which will help us generate the right work into the future years. Next one, please, Ollie. And it's also just worth noting that as a part of that guidance, health and wellbeing boards had a refreshed role envisaged for them. This guidance was not significant or particularly material, but there are some things in the paper which I think are worth board members noting, particularly members who work within local authorities which have got health and wellbeing boards. We'll just need to make sure that we're well connected on ensuring that the ICP, health and wellbeing boards, and ICS strategy generation are all done in the right way as we move into this new way of working. Next one, please, Ollie. So I'm just going to finish off with a really quick little timeline for what the next 6 months ahead looks like. Mentioned already that the ICP Assembly is going to meet for the first time by the end of September. That's the 29th, next week. During October, we'll establish the strategy refresh programme and the supporting needs for the ICP so that the ICP can come back together again in November and discuss and consider some strategic choices for what the strategy refresh may wish to focus on. In December, that draft refresh strategy will go to NHS England, the Department of Health. And as we go into 2023, we'll move away from kind of a really rapid focus on strategy refresh and more into our envisaged business as usual for the ICP, where we'll focus on that assembly meeting 3 to 4 times a year, looking at wide determinants of health in their broadest sense and our vision and values as a system as well. So I've rattled through that relatively quickly, so apologies, but again, happy to take any questions that people might have around the detail that sits within there.
Thank you very much, Sam. And comments and questions, please. Thank you. Neil.
Thanks, Bria, and thanks, Sam. I'm hugely supportive of the way forward. I think that's a very pragmatic approach, and as someone who was involved in the development of our previous strategy, I'm particularly proud of the level of engagement we had to build it. So I'm with you very much, Sam, in terms of not wanting to lose all of that. I guess my only point for us to consider, probably beyond the December deadlines, though, is just recognising the impact of the last couple of years. And I think the level of kind of recalibration that will be needed. If the strategy is about where are we going to, and how do we get there, we're in a very different place now to where we were when we developed the strategy in the first place. So I think there will be a need for us just to kind of reset both where we're starting from and the level of ambition we have in the current kind of context we're operating in. But I'm really supportive of the way forward.
Thank you. And Ilona?
Thanks, Bria, and thanks, Sam. A really helpful update paper. And like Neil, I'm supportive of the approach you've outlined. My one question, which is maybe something we just build on in the future rather than get an accurate response to today, is how we make sure we have good clarity of the ICP versus the ICB role and get the best from both, as it were, and avoid the risk that I see of potential duplicated effort. So that's just something I'm kind of alert to and want to make sure we keep an eye on. So any initial reactions welcome, but otherwise that's something I just want to make sure we address going forward. Thanks.
Yeah, thanks, Ilona, and thanks, Neil. Welcome both comments and agree with you. Ilona, on your specific question, I mean, I think we should recognise they are both quite different constructs in what they are set up to do. The ICP really is kind of meant to be a broad partnership forum which looks at that strategy in the broadest sense. And for the ICB and for our board that meets here today, we will need to make sure that even though we are part of the ICP, and many people in this room will be in the ICP as well, we will need to make sure that the decisions we take and the initiatives which we focus on as a statutory body are sufficiently well calibrated and aligned to our overarching strategy that's been set collectively through the ICP. Now, we shouldn't focus too narrowly on that strategy construct, because I think the ICP is as much about creating the time and space to focus on those broader, wider determinants in a way where we have never really traditionally had the time and space to do that in a way which is effective. But I think, we'll have to carefully consider how we do it, but there's a really good opportunity for us to make sure those things are sufficiently well aligned, but not duplicative, like you say.
Thank you very much, Sam. And thank you for the engagement that has gone on with so many members across the system. The support and enthusiasm for becoming actively involved and part of the Assembly has been really strong. So it augurs well for us to build that strategic intent and that clarity of vision and purpose across the system. So thank you. Let's move then to our system performance update, and Richard Chapman and Sarah Bellas to take us into that. Thank you.
Sorry, Chair, just struggling a little bit because I'm not used to Zoom. Are you able to hear me?
Yes, we are. Thank
Good.
you, Richard.
Fabulous. Thank you. So there are. The intention here is to produce an integrated finance performance and quality report. We're not quite at that point yet. So essentially there are three separate segments to this report. I'm going to introduce the finance report and performance. I'm hoping Sarah is on standby, or this is sufficient notice for Sarah to talk to the quality report. So the finance report presented, the year-to-date position is a cumulative £5.4 million adverse variance to plan for the Frimley system as a whole. Now, within that, we have not just Frimley ICB and Frimley Health Foundation Trust, but also we are including numbers from Surrey and Borders Partnership and Berkshire Healthcare FT, as they are not formally part of the Frimley Integrated Care System, technically part of the Integrated Care System, but they are very clearly key providers and key partners within our system, and therefore we have taken an approach where we include their figures within the overall Frimley Integrated Care System. So year-to-date position, a cumulative 5.4 million adverse variance to plan. That means a deficit of £15.9 million year-to-date against a planned deficit of £10.5 million at this point in the year. We are advised that not all external funding streams are yet finalised, and so the system forecast remains at break-even, which is in line with regulatory advice. But I will bring to the board's attention that in the absence of a change in the external funding environment, there is a requirement to deliver a material step change in the system's expenditure run rate in order to remain compliant with plans. There are particular pressures in temporary staffing spend and non-pay spend, a material element of which is driven by inflationary pressures in energy and in prescribing, and pathology services and continuing healthcare are also seeing material pressures owing both to volumes and to prices. The board is asked to note the increasingly challenging financial position and the increased stretch efficiency target that the system will need to deliver over the remainder of the financial year. Happy to take any questions, Chair.
Thank you very much. Colleagues, comments and questions? Alex.
Thank you, Richard. Potentially a challenging and risky outlook for forecasts when you look at some of the income assumptions, and you've just referenced a step change in expenditure needed, and we're moving into winter at our most challenging time. What kind of support have you got to kind of outline the financial actions and impact that we can achieve alongside the stability and further improvement impact we need to get into the system? Those two things seem quite challenging.
They are quite challenging. Sorry.
Should we just hold a second and bring in Ilona as well, and then come back to both questions? Thank you both.
Thanks, Priya. Richard, I just wanted to get clarification from you about the inflation assumptions. I know energy's pulled out specifically in your paper, but I wanted to just check whether the full year forecasts now, what they assume on assumption is around inflation. Is it still what was assumed in the June budget plan, or have they been updated, or will they be updated at period 6? And if it's the latter, what level of risk should we be showing against that as a result? Because I could see there's a kind of generic risk pressure thing, cost pressures, but it didn't tease out inflation specifically. So I'm kind of trying to gauge how much worse could this get. So you talk about needing to take remedial action, but this looked like a very worrying position to me. And also just on agency spend, it looked, from my reading of it, and I may have just misinterpreted what's put in front of me here, that we were already year to date over the cap that we've been set. And I wanted to understand the implications of that, particularly given from a delivery perspective, we have workforce pressures that we need to address. So this feels like a very tricky balancing act for us. And I just wanted to understand that specific point about the cap and how it works if you breach it. Thank you.
Thanks very much, Rich.
Okay. Yeah, I'm off mute. Helpful. I think actually, so the first part of, sorry, Alex's question and the last part of Ilona's question around agency staffing are linked, and to link them, I've gone through balance of risk in terms of performance and our capacity to meet healthcare demand challenges alongside clearly our duty to live within our financial resources, and capacity is linked to temporary staffing, and our ability to live within financial resources is linked to temporary staffing. So I think there's a golden thread that runs through there. Just I'm going to take the second part of Ilona's question first. So what we haven't done in the finance report is included a sentence that clarifies that the £19 million agency cap for the Frimley system only refers to FHFT. So Surrey and Borders and Berkshire Healthcare agency caps are included in their host systems reporting, whereas we do include Surrey and Borders and Berkshire Healthcare's full expenditure. So we haven't yet breached the £19 million cap for Frimley. But if we take Surrey and Borders and Berkshire Healthcare's current temporary staffing spend out of the year-to-date position, we're at 14.3 million against that £19 million agency cap. So unless something truly unexpected happens, it is likely to be breached by about halfway through the year, as operational demand, assuming that operational demand continues at current levels. Caroline referenced earlier the work of the temporary staffing team on impacting the rates that we are paying for those temporary staffing, which therefore, I mean, that has been some very efficacious work. And were that not there, then it might well be the case that we're approaching the cap already at this point in the year. So, and that's purely the price that we are paying for temporary staffing, and it's driven by, and we'll come on to the performance report, and you will see that it is driven by the demand that is being placed on the different healthcare partners within the system. In terms of the inflation question, so energy is the main inflationary pressure that we're focusing on. The pay award has been funded nationally, and that's what's reflected in our risks already. There will be impacts on clinical consumables, but that's a little bit harder to quantify, and potentially will be mitigated by national purchasing arrangements. Inflationary pressures on prescribing are referenced in, I think it's in the paper, and I referenced it in my verbal description, which is already accounted for in our forecasts, which are looking at something in the region of £8.4 million above plan, and that's a combination of both price increases and volume increases, and we're working through the price volume mix, kind of case mix on that. latest figures are based on the intelligence we had at month 5, end of August, so we're not anticipating a further adverse deterioration owing to inflation, but the macroeconomic environment is pretty unstable, so one never knows. I think there's not a very great deal I can say in terms of the forecasting of inflation in addition to that. And then Alex's first question, so what support do I have? What support do we have? And I think it is we, not I. So we can report the numbers, we can forecast the numbers. We have and are developing the ICB's governance to enable us to operate in the way that we need to operate going forward. But there is a balance of risk between our duty to remain within the financial resource that is delegated to us and our duty to meet the healthcare demand in the population. As we come on to the performance report, that will kind of describe some of those demand pressures that we are seeing at the moment.
Thank you, Rich. Onwards to performance, please.
Sure thing. So the performance report as presented contains highlights of the system's performance and I think reflects the extreme pressure under which NHS services in Frimley, in common with everywhere else I think in the country, are currently operating. So highlights include that primary care appointments are 15% above the equivalent month's activity in the 21-22 financial year. ED attendances remain extremely high and acute bed occupancy is above 96% at both Frimley and Wexham Park. As a result of that situation, or largely as a result of that situation, ambulance handover delays remain high, so there's 68% year-on-year increase in delays and a 96% increase in delays of more than 60 minutes. Outside of that primary care to acute pathway, so urgent community response is responding well, is doing everything it can. So we saw 95% of 2-hour appropriate referrals within the 2-hour target in July, which was 268 of 282 referrals. Demand remains high for adult mental health and learning disability and autism services, and access targets for children and young people, particularly in eating disorders, remain extremely challenging for us to meet. So I guess it's painting a picture of a service that is under very high demand pressure, and I'm happy to take any questions on that, Chair.
Thank you. Should we have the quality update from Sarah and then have questions after that, please? Sarah?
Sorry, thank you, Chair. Is somebody able to project the report? I'm sure everybody's seen it. So I think the whole...
Definitely, Sarah, take it as read. Thank you.
Okay, thank you. So I think the whole meeting has really emphasised the pressures on the system with demand and everything else that we've talked about, and the workforce and the key risks and things. And I think the quality report highlights the impact across health and social care. You can see from the report that we are starting to see providers across the system struggling around the pressures of the demands and the workforce and things, and we are seeing organisations with such as the ambulance services that are under extreme pressure, requiring CQC notices and support, and there is intense pressure on that, and the impact on our population obviously as a result of that. We're also seeing primary care practices beginning to struggle with a practice on it that's the report was published in the last week since writing the paper, and that practice is rated as inadequate, and that has started as a result of difficulty around staff recruitment. In addition to that, we are seeing the issues around care homes, and we're starting to see more care homes struggling around CQC, and again that's the impact on our population. I think it's really important to note that we are working with all the different organisations trying to improve in order to meet this demand and to make it as safe for our population as possible. Amidst the doom and gloom, there is lots of positives. So as Fiona alluded to at the beginning of the meeting, we are trying to reframe how we look at it, and we held a rapid quality improvement meeting in August, and actually that was great, having a different kind of space where we looked at the challenges around urgent and emergency care, and there was lots of optimism and positivity around that, and there's a commitment to carry on looking at that and making that hope to look towards winter with positivity and some firm plans. And I think Sam outlined some of that in his presentation. And then I think the final thing really to talk, or final two things. One is to look at the positivity around the Ockenden visits that have just happened at both Frimley Park and Wexham Park hospitals. And despite all the challenges, they're still delivering care against those Ockenden standards. And then the final thing is the national review around children's in relation to the Doncaster Children's Home, and then you'll see the response that we're doing as a system. So I think what we can see from all of this is the pressure and the demand is beginning to show its impact on both on providers and what's happening to our population.
Thank you, Sarah, very much, and thank you, Rich. So as Richard said, we will be able to show an integrated report from next time. And of course, the underlying factors of infrastructure will feed into that, estates and digital as well. So really helpful to have that overall view. Questions and comments for Richard and Sarah? We've had a number of conversations in relation to this triangulated view, integrated reporting view, so thank you. We go on then to our modern slavery statement, and I'd be grateful for confirmation that you are happy that we adopt this statement and it is approved by the board. As you know, these are statements that are really very important to us, particularly for the populations that we serve as well, and it's very good to see this having been drafted in accordance with guidance. May I have confirmation? Thank you. And then back to you, Rich, for the Frimley CCG as was annual report and accounts. Thank you.
Thank you, Chair. So this report is presented in lieu of an annual general meeting in 2022, and the board is asked to note at this public meeting the annual report and account for the 2021-22 year. Now, the members of the board are asked to note that the final audited Frimley CCG annual report and accounts have been published now on the public website. As a brief descriptor, so the CCG spent £1.3 billion, which equates to approximately £1,440 for every person registered with our practices. Within that, the CCG reported an in-year surplus of £5.5 million and incurred COVID expenditure of £57.4 million, of which 8.2 was on the hospital discharge programme, around £6 million was spent within primary care, and £42.3 million was provided to Frimley Health to support acute capacity. We deliver continued investment in mental health services, meeting the mental health investment standard, and continue to work in partnership with local authorities through the Better Care Funds, which totaled £58.5 million, supporting greater integration. As a summary, the CCG achieved its financial duties for the year, stayed within its revenue resource limit, its running cost allocation within allowable limits for cash in bank at the end of the year, and received unqualified reports for audit, for regularity and for value for money. Happy to take any questions, Chair.
Thank you. I'm seeing acceptance around the views. Thank you very much, Rich. Good. Well, let me ask members then, are there any other items of business? No. Very grateful for a question from a member of the public, and over to you, Sam.
Yeah, thank you, Priya. We've received a question from a member of the public around the role of the voluntary sector in the Frimley ICS. I can see that the person who's asked the question is in the meeting with us today, so thank you so much for your question. We will make sure that you get a written response to your question, which is more detailed than the one that I can give you right now in the meeting. And a member of the team is really happy to meet with you as well to discuss it in greater detail. We've got a member of our partnerships and engagement team who would be really happy to have a further conversation if that's helpful as well. So thank you again. Just to say, for the benefit of the board, the question which was asked was around the role of the voluntary sector and the charity sector in working with the ICS, with particular reference to funding for peer support groups. And just to note, in lieu of that written response, clearly the voluntary sector is a hugely important part of our system partnership. We really welcome the links between our statutory organisations, the voluntary sector and the charity sector as a part of that, and that was never really demonstrated in greater effect than during the pandemic, when that sector played an absolutely vital role in mobilising volunteers and broader support to both the health and social care system as a whole, and directly to members of the public and the population through the support that was provided. We're completely committed as an ICB and an ICS to working closely with the sector in a range of different ways. We'll continue to explore how we can provide a greater unified voice for that sector, a more clear and open front door into the ICS for organisations in the charity sector and the voluntary sector, and to ensure that through that partnership we can amplify the voice of our vulnerable and often unheard parts of the population as well. So I know that's a rather brief response to your question. We will make sure you get a full written response, and very, very happy to make some additional time for a conversation outside of the board environment. I hope that's helpful.
Thank you.
Thank you very much, everybody. We've covered a lot of ground today. Very good to have had time on our strategic ambition whilst being absolutely grounded in the reality of today and improving that experience for all our residents. Thank you, everybody that's contributed today and who has created the board pack and papers. Take care, everybody.
Thank you, Priya.
Bye.